Welcome to Hope Blooms, a podcast from the Early Pregnancy Loss Association.
At EPLA, we seek to support women and families suffering early pregnancy loss by providing resources, education, and community. It is our vision that no one suffers miscarriage alone. Welcome back. I'm EPLA's Executive Director, Emily Carrington, and I'm joined by our President, Maria Serbold. In 2018, I spoke with Dr. Marguerite Duane, co-founder and executive director of FACS, a group of physicians, educators, and healthcare professionals who provide information about fertility awareness-based methods of family planning with the medical community.
Dr. Duane is also an adjunct associate professor at Georgetown University and served as a physician with modern mobile medicine.
In this episode, recorded in 2018, Dr. Duane and I had a conversation about various terms and common treatments associated with early pregnancy loss. We also discussed frequently asked questions from women and families following a miscarriage.
Hello, and welcome to Hope Blooms, the podcast of the Early Pregnancy Loss Association. I am Emily Carrington, the president and co-founder of EPLA. Today we are going to talk about miscarriage from a medical perspective. We believe that education and information are powerful tools when navigating pregnancy loss. But unfortunately, years of a hushed culture that doesn't talk about miscarriage has led to a lot of misunderstanding and confusion about early loss. Personally, after my own first loss, the doctor used terms like missed miscarriage and DNC. I'd never heard these terms before and left feeling confused about what had happened to our little one. We are so happy today to have Dr. Duane as a guest on our podcast to help us understand a little more about miscarriage and early pregnancy loss. Welcome, Dr. Duane.
Thank you for having me.
We're so glad to have you. Could you please take some time to introduce yourself to our listeners? We'd love to hear a little bit about your work as a direct primary care physician and how long you've been in practice as a family doctor.
Sure. Again, my name is Dr. Marguerite Duane, and I am board certified in family medicine. As a family physician, we are trained to care for patients at every stage of life and at every age. In my first few years in practice, I did do full spectrum family medicine, including prenatal care and deliveries here in the Washington, D.C. area. Now I really focus my time as a medical professional focusing on fertility and teaching women to better understand their cycle using fertility awareness-based methods and working with couples who are trying to achieve pregnancy, who may have experienced miscarriage or difficulty conceiving, as well as helping couples who desire to prevent pregnancy using non-hormonal or artificial means to prevent pregnancy. I do this through my work as a direct primary care physician with modern mobile medicine, which is an entirely house calls-based practice here in the Washington, D.C. area. I also do a lot of work to educate my medical colleagues about fertility awareness through FACS, which is the Fertility Appreciation Collaborative to teach the science. And our website is factsaboutfertility.org. But I think women's health, and especially when it comes to reproductive health and pregnancy, is a really important topic. And I'm happy to be here today to talk to you about it.
Great. Thank you. So as a family doctor, and obviously with a lot of focus on fertility and fertility education, how often do you see patients who are experiencing a miscarriage? People might think that this is something only OBs deal with, but family doctors see these as well, correct?
Well, yes. In fact, I think in many ways, family physicians deal with this on a more regular basis because the majority of miscarriages happen during the first trimester. And if a patient has yet to establish care with an OB, it may be their family physician that is seeing them for this need. Although my practice currently is very, very small, I actually do see it a fair amount. And that's because miscarriage is actually very, very common. Although we may not talk about it as much, nearly 1 in 4 women will experience an early pregnancy loss in her lifetime. And estimates show that about 30% of all pregnancies will end in miscarriage, although many of these will happen before a woman may even realize that she's pregnant. And again, the overwhelming majority of miscarriages that happen do occur in the first trimester, that is within the first 12 weeks of the pregnancy. And so as a result, family physicians may end up managing many of these women and patients that are experiencing this condition.
Makes a lot of sense. And as we're talking about this, could you explain for our listeners a little more detail what you mean when we talk about miscarriage? What is a miscarriage?
That's a great question. Miscarriage is actually the term. It's not the technical medical term to describe an early pregnancy loss. The technical medical term for a miscarriage is actually called a spontaneous abortion. And for some people, the term abortion itself has become a very politically charged term, and it's hard for people to hear that word. But a miscarriage is a spontaneous loss of pregnancy, technically before 20 weeks gestation. And again, the diagnostic term that we use, the official medical term, is a spontaneous abortion. Now, there are further terms that may be used, and I know you mentioned or alluded to this early on. There's what we call an incomplete abortion. In that case, it's a early pregnancy loss or a miscarriage where the baby, there is no viable pregnancy or viable baby, but the woman has not yet passed all of the products of conception. So an incomplete abortion happens when you can no longer detect, or you're not able to detect, any fetal cardiac activity or signs of human life, and yet there are still what we refer to as, there still appears to be products of conception within the uterine cavity, and the woman has not completely passed that. So that's what we refer to as an incomplete abortion. An induced abortion is what people typically think of as an abortion. It's the end of a pregnancy that is a result of an action taken by a medical professional or a person to deliberately end a pregnancy. That's what we refer to as an induced abortion. But a spontaneous abortion or miscarriage is the unexpected or unanticipated loss of a pregnancy at its earliest stages.
Great. That really helps explain sort of some of those early terms. And there are some other types of early pregnancy loss that we don't often hear about, correct? Such as ectopic pregnancies and stuff like that?
Correct. So ectopic pregnancy occurs when the human embryo implants outside of the uterine cavity. So normally pregnancy or human life begins at fertilization, when the egg and the sperm unite, and that occurs in the distal fallopian tube. And over the next 7 to 10 days, that developing embryo will rapidly divide, and in about 7 days afterwards, it will actually implant into the lining of the uterus, where, if all goes well, the baby will continue to develop and grow for the next 9 months. In some instances, after fertilization has occurred, as the embryo is developing, the embryo may actually implant before it reaches the uterine cavity. So it may implant into the fallopian tube. Sometimes it may actually implant into the abdominal cavity. Anytime the human embryo implants outside of the uterine cavity, we call that an ectopic pregnancy. And in those cases, the pregnancy itself is not viable because the fallopian tube is not designed to be able to handle the growing embryo, and that could actually put a woman at risk for loss of life. So an ectopic pregnancy can be a medical emergency and needs to be addressed, ideally by removing the section of the tube where the embryo has implanted to basically safeguard and protect the mother's life.
Right. Well, and you started talking about the sort of the treatment options. With an ectopic pregnancy, there's emergency procedures that need to take place. With a typical miscarriage, especially in the case of the incomplete miscarriage we were talking about, what are some of the treatment options that a doctor might talk to their patients about?
So a lot of the treatment options will depend on how far along the woman is with the pregnancy, because if it's still very early on, in some cases you have the option that we call expectant management, or simply waiting and watching to see if the woman's body will normally expel the pregnancy as just as a normal part. That you can do that early on. As you get further along, though, you may need to take medication or have what we refer to, and you mentioned this earlier, a DNC, which is dilation and curettage, to actually remove the remnants of the pregnancy from the uterine cavity. So in terms of management of miscarriage, again, there are different options. And this is where it's going to be really important for a woman, to consult with her physician to determine what is the best treatment option. there are a number of factors that may influence which treatment path they go down, whether or not the woman is having any bleeding or cramping, whether or not she's passed any blood clots, whether or not she has any other medical issues, and again, how far along the woman is in the course of her pregnancy. From a personal experience, I can share my mother experienced 2 miscarriages. And with her first miscarriage, she was 8 weeks along in her pregnancy. And it was still early enough that the doctor allowed her to just pass the products of conception naturally without needing any further intervention. With her second pregnancy, she was actually 12 weeks along, and she was having a significant amount of bleeding, and there was concern about her hemorrhaging. And so it's not unusual that far along to recommend what we call a dilation and curettage. And what that refers to is dilation refers to they actually dilate or open up the cervix. And the curettage is they use an instrument to basically clean out the contents of the uterus. Again, for some people, this can, just hearing those terms can cause some anxiety because DNCs may also be used as part of an induced abortion. And so some women may have some concerns, that they don't want to do anything, unintentionally. But if the pregnancy is no longer viable, it is important in a timely manner that the uterine cavity eliminates the remnants of the pregnancy. Otherwise, it could pose risk for bleeding or infection for the woman.
Absolutely. That's really helpful. I know I've heard lots of women say it can be really sort of scary to take an action like that if you don't understand what's going on. So that's very helpful.
I think sometimes it's a challenge for women because, in many of these instances, when a woman miscarries, this may be a very wanted pregnancy. And unfortunately, we live in a society now where the value of human life at its earliest stages is not necessarily given as much weight or given as much value by all people. And I think some women are concerned, is the doctor that they're going to respect and value, this woman's pregnancy and this baby like the woman does. And so she wants to know that she's got that level of support. And again, unfortunately, we see this oftentimes in the medical community because as a physician, and especially as an obstetrician gynecologist, you may deal with miscarriages a lot. And so it just becomes another number for you or another procedure. But for the woman that is going through it, even if this is her second or third, it's still it has a different impact on her emotionally. And so sometimes it can be challenging for women to feel like they can find, the physician that can provide the appropriate level of support to the woman and respect, for the life of the child that she's just lost.
Absolutely. That's absolutely true. Following miscarriage with your patients, what are some frequent questions that women and families come to you after being diagnosed with a miscarriage or experiencing a miscarriage? What are things they often ask?
Immediately, they often ask, well, how long can they expect to experiencing the bleeding and the cramping? Oftentimes, they will ask what caused the miscarriage or is there anything that they can do to figure out what caused the miscarriage? Another question is, frankly, like how soon after a miscarriage can we engage in sexual relations? And then beyond that, how soon after a miscarriage can we try again if they've been trying to get pregnant? So those are a lot of the questions that we experience. And again, the answers are going to vary depending on the person and how far along she was in the pregnancy and any issues, that she might have experienced as a result of management of the miscarriage. A woman who has lost a baby early on and we did expectant management and she was able to pass everything naturally without requiring additional medication or, a procedure, she may be able to resume sexual activity sooner. She may, have bleeding for a shorter period of time, whereas if a woman is further along, that might affect the management differently. A lot of times I'll get the question, how can I prevent this from happening again? And the reality is in some cases, there's nothing that we can do to prevent it. It's thought that up to half of all miscarriages are due to chromosomal abnormalities. And unfortunately, there's nothing that can be done to prevent those. I mean, there are certainly women of advanced maternal age or husbands, fathers of advanced maternal age, you have a higher risk of chromosomal abnormalities, but there are many women in their 40s that have healthy, normal pregnancies. I mean, I myself had 2 children after the age of 40 without any complications, but you can't prevent necessarily chromosomal abnormalities. One of the things that I do, though, I have an example of a woman who experienced 2 miscarriages this year within 6 months. And she had previously healthy pregnancies without any difficulties. And she was in her, late 30s. So, she was technically of advanced maternal age, but she wasn't, in my opinion, she wasn't very old because she was only in her late 30s. But one of the things that I encouraged her to do was I wanted her to start charting her cycle, because one of the benefits of using fertility awareness-based methods is you can assess a woman's reproductive health. I like to refer to the chart of the female cycle as the 5th vital sign. It really gives us very valuable information into a woman's hormonal health. And if I can look at a chart, if I see women with short luteal phases, and this is the period of time after ovulation until the next period, a normal luteal phase should be 11 to 16 days. On average, it's about 14 days. But if I see women with very consistently short luteal phases that are 8, 9, 10 days long, these are women that I think might actually be at an increased risk for miscarriage and increased risk for recurrent miscarriage. So in the case of the patient that I was referring to, when she tried and got pregnant the 3rd time, I was able to start her on appropriate hormonal treatment support to support that pregnancy. And now I'm happy to say she's 18 weeks along, with this 3rd pregnancy after having experienced 2 miscarriages. But it was because we identified a potential hormonal imbalance that may have been contributing. So unfortunately, most medical professionals are not well-versed in fertility awareness-based methods and are not well-versed in how to use the chart of the female cycle to identify and address reproductive health issues, including short luteal phases that could increase a woman's risk for miscarriage. But if people are looking for that, I would advise them to visit our website, factsaboutfertility.org, and reach out to us so we can help them find trained medical professionals in their local area that could help in this instance. So those are some of the common questions that I get. And that's, a common approach that I will take, is I will try to look at, are there issues that I can help address? I mean, there are certain risk factors, again, advanced maternal age, I can't change that. But if a woman is smoking or drinking a lot of caffeine, which may be associated with early pregnancy loss, I can work with them to help them modify those behaviors. Certain infections may place a woman at increased risk for miscarriage, sexually transmitted infections. So again, we want to look at that and treat accordingly and make sure to maximize the woman's health before a future pregnancy.
That's really great. And I know for many, myself included, moving forward can be a very difficult step, especially once I started dealing with recurrent loss. The thought of moving forward was very difficult. But the idea of getting my body healthy was something that I knew I could do. So looking at hormonal shifts and stuff like that wasn't necessarily personally for me about getting pregnant the next time, but about getting myself healthy and ready. So that's something. But for women who hear the words charting and luteal phase and that it's all just very overwhelming, can you sort of give some encouragement about sort of what this process is? I think there's, not to go down this rabbit hole too much, but that there's also a lot of misunderstanding about charting and the difficulty of charting and what you're actually able to figure out and what it actually means.
Right. No, that's a great question. I think it can seem overwhelming, but when women actually learn how to chart their cycle, I describe it when I first talk to women, it's like riding a bicycle. I mean, the thought of like, how do I balance and steer and not fall off and keep going forward? If you try to think through it, it's hard. But once you get in the habit and you've developed that skill, it becomes second nature and you don't even think about it anymore. So at FACS, we have a presentation that we call the Signs of the Female Cycle Explained. We offer this as a webinar. We've got one coming up on December 13th, where we basically describe what are the signs that women can learn to chart. And we really encourage, if women want to learn how to chart their cycle, to find a trained educator to teach them. And I'm a big believer, this is something every woman of reproductive age should learn, even adolescents, just to understand what's happening in their body. And it's really as simple as when you go to the bathroom, remembering to wipe before as well as after, to pay attention to the sensation, to look for cervical fluid signs. Just charting cervical fluid alone can be a good indicator of the health of your overall cycle. So it's like going to a gym. You can walk into a gym and there's all of this fancy equipment, and you might want to try and sit down and start lifting weights. But without guidance from a personal trainer, you're a little bit higher risk for injury. So, you could try and pick up a book or an app and figure it out. But I really encourage people work with an instructor that can explain the basics. And once you're able to develop this skill, again, it's like riding a bike. You don't forget it. It becomes very second nature. And it's not nearly as overwhelming as it might seem to begin with. And the benefit is it provides just a wealth of information, not only about your risk for miscarriage, but, knowing when you can expect your next period, understanding, the hormonal changes you might experience, right before your period. So it's not a surprise. It's like, oh, this is where I am in my cycle, and this is what I can expect. And as I said, it has the added bonus of being able to identify potential, risks for things such as miscarriage.
That's great. That's really helpful. And I want to go back to those days and weeks following loss. And what should a woman, and of course, as we've talked about, every miscarriage is different, and it's important to work with your doctor. But what should a woman expect in the days and weeks following loss, physically, emotionally, and hormonally? Sort of, there's a lot going on.
Right, from woman to woman, depending upon how far along she is in her pregnancy, depending on, the desire for the pregnancy, depending on the support she has from the baby's father. I mean, there's a lot of factors that may affect physically after loss. It's common to experience bleeding, sometimes heavier than a normal period, but it shouldn't be that much heavier. And if it is, if she's passing large blood clots or having to change a tampon or pad more frequently than every 2 hours, then that would be a sign that there could be something wrong, and she should see a doctor for that. But, she should expect heavy period bleeding, sometimes 3 to 5 days, up to a week. Hormonal changes, again, if she's been further along in the pregnancy and all of a sudden, she experiences a loss, she's going to go through significant hormonal shifts, and that's going to affect her emotionally. Women will experience there's no rule book. There's no typical miscarriage experience, because it really depends on the individual woman. What I would say is, to friends and family of women that have miscarried, be there, offer a listening ear. Some women want to talk about it, some don't. But, oftentimes I think well-intentioned people will say things that they think sound helpful, but can actually cause a lot more pain to a woman. So I encourage friends and family to listen more and talk less, and be a source of support, because, the woman may seem fine one day, but, inside her heart is really breaking and she's really struggling. A woman who might not have been super excited about the pregnancy might feel a sense of relief, and that is then associated with a sense of guilt. And so really range of emotions. What's important is that, as friends and family and as medical professionals, we're there to support them, to listen to them, and to help guide them along the way. And to recognize too, it may seem most intense in the days and the weeks after the miscarriage, but a year later, around the anniversary of the due date, these feelings may all come up again. And just, again, allow the woman and the man. Because it's also a loss, for the father. Let's not forget about them. This may be difficult for them too, so that we're providing appropriate support for the couple, and recognizing that it may vary. And it's just really important to be there to lend a listening ear and to be as supportive as you can for the woman or the couple that's dealing with the loss.
That's great advice. I know personally it was just and is always a roller coaster, especially right away, but then anniversaries and holidays, and just the whole experience was a roller coaster. And the best support were the people willing to just listen and walk through it with us. Mm-hmm. We've talked a little bit about moving forward and looking at your overall health. When should a woman and her family consider time to start testing? to find the potential cause. I know we talked too about how there could be a whole host of causes, and it's sometimes hard to find them. When should they start considering doing these testing, and what's a good way to get started on moving forward when a woman and her husband are ready to move in this direction?
I really encourage them to start charting, because I think that's a very simple, non-invasive way that's empowering for them to help them better understand what is happening with their body, to see if there's anything in terms of the woman's reproductive health that may increase her risk for recurrent miscarriages. Typically, most medical professionals will not consider doing any testing until a woman has experienced 3 pregnancy losses. And that's due to the fact that, these losses can be considered very common. But, I would often, even after a first loss, look, are there any signs of, infection that could be contributing, because that's something that we can treat. So again, my goal is to optimize the woman's health. I would say, if you've experienced a loss, if there's any signs or symptoms or risk that you could have an infection, be evaluated and treated. Again, do what you can to optimize your health. But beyond that, I think most medical professionals will not even consider testing until a woman has experienced 3 losses. But I don't think that should leave women feeling they can't do anything. I think there's a lot women can do, starting with charting her cycle and doing everything she can to minimize those risk factors for miscarriage that she has control over. Things, again, like we said, alcohol use, caffeine use, cigarette smoking, chronic diseases, like if a woman has high blood pressure or thyroid disease. I mean, those are things she should really work to get under control as best as she can to maximize her chances for having a successful and healthy pregnancy in the future.
That's very helpful. Thank you. And those are things that I think, we can all be doing to be healthier. I guess this is my final question. Of course, it's important to be healthier, but I also know there's a lot of guilt surrounding miscarriage, that women often feel like their bodies have failed or they have somehow failed. How do you respond to a woman who's struggling with feelings of guilt following the miscarriage?
Yeah. And this is something we see a lot of. I think as women, we're almost preconditioned to take responsibility for what happens to our children. I think that's it's a good trait to have to a certain degree, but I think it does make us more susceptible to the guilt of what could I have done. And what I will oftentimes tell women, again, the majority of miscarriages are a result of chromosomal abnormalities, that there's absolutely nothing you could do. I mean, it's just literally the luck of the draw in terms of which sperm met which egg. And in those cases, we don't know if it was an issue, a chromosomal abnormality on the male part or the female part, or maybe it happened during the division process, in which case there's absolutely nothing we as women can do. And I really encourage them, to, rather than focus on, feeling guilty about what they could have done or could not have done, I really encourage them to focus on valuing, the life that was, and to focus on, in some instances, the positive of, you were able to conceive. There are many people that may struggle, and I try and help them focus on the positive. Yes, that you've experienced a miscarriage, but there are many positives that can come from this, and we can use this as a growth, as an opportunity to grow and to learn more, and to focus on all of the things that they're doing well and they're doing right. And I remind them, there's so much in this world that is out of our control. And especially in terms of miscarriage, it's very rarely the result of something that the woman has done. It's more often just a result of, factors that are beyond her control. And so I really encourage her not to feel guilty, but rather to use her energy to focus on healing.
That's great. And I know 4 years following my 3 miscarriages, I'm finally at a point now where I do remember my children very fondly and have good and happy thoughts, even though at the time it was a very dark and difficult time for me and my family.
Mm-hmm.
they now do bring me joy years later. Well, thank you so much. Is there anything else you would like to add that we've talked about or haven't talked about today? This has been really informative, and I think our listeners will learn a lot.
Well, I just want to follow up on that last thought of, at the time that a woman experiences a loss, it is a tremendous loss. And it's hard then to see what good can come out of it. But I can certainly say from my own personal experience, I discussed the fact that my mother experienced 2 miscarriages. And this was in the early 1970s when we actually knew very little. But my mother was a nurse, and she knew what happened during a miscarriage and what happened afterwards. And she recognized, the humanity in her children. And she was able to preserve the remains and were able to identify, that she had miscarried 2 boys. And so as a mother, she always shared that with us. And so I always grew up recognizing the humanity of my brothers that, did not enjoy life on this earth. But I recognize them and their humanity. And with the second miscarriage, my mother did conceive shortly thereafter. And for me, it's always been difficult because on the one hand, I lost a brother early on at just 12 weeks gestation, but I gained a sister who, whose birth inspired me to become a physician. And so while I experienced and experience that sense of loss and sadness of, not having these brothers here on earth, I realized their lives very much had meaning. And again, at the time, it's hard to comprehend, the joy that could come from such loss. But I also see the beauty that has sprung, from their lives. And part of it for me as a physician, it's developed in me an empathy for my patients who have experienced miscarriage, because I recognize the humanity in that loss, just as I recognize the humanity in the loss of my own brothers. So, so at the time, this may seem very, very difficult and you may not understand the why, but I would encourage you to not lose faith and to not lose hope and to trust that there is a greater good that may come from this experience and to hold on to your hope for the future.
Absolutely. Absolutely. Well, those are beautiful closing thoughts. So we will let it there. Thank you so much. We are very honored to have you on this podcast. And I just think it was a very great conversation. So thank you for joining us.
Thank you. It was my pleasure.
Thank you for listening to Hope Blooms, a podcast from the Early Pregnancy Loss Association.
To learn more about how we and you can support women suffering early pregnancy loss, visit our website at miscarriagecare.com or find us on Facebook, Instagram, and Twitter. Thank you for listening.